So today I will do a brief introduction to a person brought in coma. Okay. So we will start as usual. It's only like any other topic. I only do a small template on which we have to build each case individually. So we shall start with the definition of terms, evaluation, and the implications and the take-home message like that. So I will today do coma, next I will do the brain death. Then I have requested that I need the list of topics I have presented because now students are not taking up any presentation, in which case it will be easy for me. So now I have to choose what topics are to be covered. So if I get the things done, I will be able to choose. So we'll go through definition. First, consciousness, and the other extreme is coma. So consciousness is a stage of normal awareness of the self and surroundings with the ability to respond to all types of stimuli, both exogenous and endogenous. Properly. So as we know, consciousness has got two parts. One is the level of consciousness and second is the content of consciousness. Commonly, we measure the level of consciousness with the Glasgow-Coma scale, and content is measured with the domains of cognitive function. The level of consciousness or arousal, otherwise the wakefulness, is mediated by the reticular activating system. The content of consciousness or awareness, which includes the cognitive and affective aspects of cortical function, modulated through the subcortical interactions. Content means you have the frontal lobe functions that is involved in attention, orientation, judgment, personality. Parietal lobe is spatial orientation, temporal lobe, memory, occipital lobe, visual, and other associated functions. All these become altered means it is a content of consciousness. And during sleep, the subject can be aroused by appropriate stimuli to full consciousness. So sleep is another level of consciousness. So first you have got what is consciousness and its parameters, that is the content and the depth, and what is sleep. So sleep is another kind of unresponsiveness, but patient can be aroused by appropriate stimuli to full consciousness. And coma is a state of unarousable unresponsiveness. So unarousable. So sleep is arousable unresponsiveness, whereas coma, what we are going to talk today, unlike sleep, is unarousable unresponsiveness, which implies defects in arousal, awareness of the surrounding, and ability to respond. And there is no sleep-wake cycle in coma. So in coma, generally the eyes remain closed and the sleep-wake cycles are absent. So in the normal sleep, you have got NREM, we are having REM, we go to sleep with NREM and wake up with REM. And that sleep-wake cycle is going on. So in coma, sleep-wake cycle is not there. That is one point by which it is different from coma. Second, coma is unarousable, but sleep is arousable. The common thing is both of them do not respond to environmental or internal stimuli during that phase. What is vegetative state? It is wakefulness without awareness. So apparently patient lies with the eyes open and we will think he is awake, but he does not respond or interact. That is vegetative state. So wakefulness without awareness. So sleep, coma, and vegetative state. Sleep is unresponsive but arousable, and sleep-wake cycle is there. Coma is unresponsible but unarousable, and sleep-wake cycle is not there. And vegetative state is awake but not aware. Sleep is a complex, rapidly reversible neurological state actively generated by different neuronal systems using neurotransmitters and regulated by homeostatic, circadian, and ultradian influences. Not simply the absence of waking, but a special activity of the brain controlled by elaborate, precise mechanisms. So sleep is an active process. It is not a passive withdrawal. It's an active process meant for various functionings of the internal milieu. So what is locked-in syndrome? Locked-in syndrome is a condition in which voluntary control of almost all body movements is abolished with intact consciousness and cognition. So patient is unable to respond physically or verbally, but he is having all the afferent limbs functioning. So this state of profound paralysis may be mistaken for coma, because we don't know how they are receiving or responding, because they are not able to express to us that they are receiving and responding. So this can be mistaken for coma. In many cases, it is due to a disorder of the ventral pons. Otherwise, we call it as a ventral pondine syndrome, which can be due to infarction or hemorrhage, and difference of all supranuclear motor circuits except those of vertical eye movements and blinking are stopped. So other than the vertical eye movement and blinking, all other different pathways are cut off. So next is the persistent vegetative state. So it is wakefulness without awareness, maintains life without appreciating, remaining so far for more than 1 month. So if they they just are awake, they are not appreciating anything that is going on, and you use the term persistent vegetative state not in 1 day or 1 week, that patient should be in that state for at least 1 month. Then you think that the person is unlikely to improve. And retain brainstem regulation of cardiopulmonary function and visceral autonomic regulation with the sleep-wake cycle. And destructive process which grossly damage the cerebral hemisphere or the upper brainstem results in persistent vegetative state. Next is brain death. So coma, so wakefulness, sleep, coma, locked-in syndrome, persistent vegetative state, and brain death. So brain death is defined as the irreversible loss of all functions of the brain, including the brain's primary functions. The 3 essential findings in brain death are coma, absence of brainstem reflexes, including respiration, and it is irreversible. So the person with altered consciousness, we have seen, it could be the disorders of conduct or disorders of arousal. Disorders of conduct is seen in dementia, delusional state, and confusion, whereas disorders of arousal is stupor and coma. And sleep, the only normal form of altered consciousness. So what are all the stages of this altered consciousness? First is normal, that is alert, awake, aware of self and environment. Alert, awake, aware of self and environment. Next is lethargy, inability to sustain wakefulness without the application of external stimuli. The patient is inattentive and mildly confused. Whereas stupor is, so patient has to be repeatedly stimulated verbally or physically to bring him to normality. Stupor, in this state of disturbed consciousness, only vigorous and continuous external stimuli. Lethargy, repeated verbal stimuli is sufficient. Stupor, in this state of disturbed consciousness, only vigorous and external stimuli produce arousal, and that is ill-sustained, and immediately the patient slips into unconsciousness. And coma is unarousable by any mechanism. So that is the different stages of consciousness. So what is this confusion? A state of reduced comprehension, coherence, reasoning, and disorientation. That is the earliest phase of patient singing in an altered level of consciousness. What is this delirium? Confusion with agitation, hallucination, tremors, and features of sympathetic overactivity, causing inability to think with the usual speed and clarity. So they are confused, they are agitated, they have hallucination, they have features of sympathetic overactivity like tremors, sweating, tachycardia, and they are unable to think with the usual speed and clarity. So vegetative state, as we have seen, is awake coma, no meaningful response to stimuli. They open eyes, they yawn, they grunt, and they swallow. So vegetative functions are preserved. That is why it is called persistent vegetative state. Vegetative function means swallowing, breathing. So that is there. So they are in the vegetative state. Then persistent vegetative state is defined as vegetative state lasting for at least 1 month. Now we will go to the anatomy. The ascending reticular activating system consists of upper brainstem and it projections to the cortex through the thalamocortical projections. ARAS is basically cholinergic. The neurotransmitters in the ascending reticular activating system is acetylcholine and glutamine. And cholinergic projections from the basal forebrain and monomonergic system, that is serotonergic, raphe nucleus, noradrenergic locus coeruleus, histaminergic posterior hypothalamus, dopaminergic substantia nigra, and ventral tegmental area are also having a role in maintaining the wakefulness. So primarily it is cholinergic and glutaminergic, but there is role for other neurotransmitters like serotonin, noradrenaline, histamine, dopamine, and they are also important. So anatomically, coma is due to dysfunction of reticular activating system, bilateral cerebral hemisphere dysfunction simultaneously, and disorders of reticular system lead to coma in which patient lacks both wakefulness and awareness. So you can see that the ascending reticular activating system through the brainstem and diffusely projects to the various parts of the cerebral hemispheres. So it is the loosely grouped neurons located bilaterally in the medial tegmentum from the medulla to the posterior diencephalon. Among these, the rostral pons to caudal diencephalon is critical for wakefulness. And reticular activating system projects to the cortex by a non-specific thalamic relay nuclei. And electrical stimulation of ROS causes arousal and thalamic nucleus stimulation causes drowsiness. So this is briefly the anatomy. These are people, Lindowski and Ligoon. They said that when they stimulated some parts of the brainstem, the brain got electrified like an electric bulb. So that is the first description of reticular activating system. So causes of coma, traumatic causes versus non-traumatic. So it can be due to trauma and non-trauma. Non-trauma, central nervous system, structures of the supratentorial compartment or infratentorial compartment affected by varying pathologies. Then systemic causes like metabolic disorders, respiratory causes like hypoxia, hypercarbia, electrolyte disturbance like hypoglycemia, hyponatremia, hypercalcemia, and metabolic causes like hepatic coma, renal coma, drugs and alcohol. And endocrine causes like hypothyroidism, hyperthyroidism, pituitary failure, adrenocortical failure, and infections like meningitis and encephalitis. There are too many causes. I am not elaborating all of them. Just grossly divide them into traumatic and non-traumatic, each system wise. You have to remember when you are evaluating a patient, for which I will show the flow chart. The neurological causes may be strokes, stochastic attacks. During the period of asystole, they produce brain damage, and low cardiac output state like persistent cardiac failure and cardiac arrest. Then infections like meningitis, encephalitis, rise in intracranial pressure, physical agents like damage due to physical agents, trauma, hyperpyrexia, hypothermia, and end-stage degenerative diseases, prion disease, demyelination, which may be post-vaccinal, post-infective and allergic, and seizures leading to status epilepticus. Other systemic causes hyperglycemia, hypoglycemia, acidosis, alkalosis, hyperosmolar state, renal, hepatic, electrolyte imbalance, calcium imbalance, phosphate, vitamin deficiency, endocrine disorders, then poisons like alcohol, narcotics, then exogenous poisons like bite by cobra and crate, and infections, several infections affecting the brain directly or indirectly. So when such a patient arrives in coma, on arrival, look at the gross general appearance. Then record the blood pressure, pulse, temperature, respiratory rate, breath sounds, and best response to stimuli, pupillary size and pupillary response, and the posturing of the patient. So the history given by the immediate attendants and circumstance of the illness is very important. Patient may be intravenous drug abusing person, or he is diabetic, taken insulin. So all these circumstances will give a great clue in diagnosis. Then general appearance, vital signs, skin, order of breath, examination of eyes, examination of fundus, eye movements and posture. Then if the patient has got low blood pressure, we have to think of, because there is, patient is unable to tell the history. That is why we have to go through a systematic approach. Which the blood pressure is low, patient may have some internal bleeding, they may have cardiac conditions, it may be alcohol, metabolic endocrine disorders, Addisonian crisis conditions like hypopituitarism, Simmons, Sjogren's, or severe autonomic dysfunction, septic shock, and high blood pressure may be hypertensive encephalopathy. So blood pressure alterations give some directions to the etiology. Then temperature. They may have fever or they may have hypothermia. If there is fever, think of CNS infection, neuroleptic malignant syndrome, diencephalic lesions which alter the temperature regulation and produce pyrexia. Then heat stroke, malignant hyperpyrexia syndrome, or hypothermia indicates endocrine disease, chronic inanition, and exposure to extreme cold without appropriate protection. Then look for raccoon eyes, that orbital ecchymosis. So if there are raccoon eyes, you should think of in a comatose patient, think of an anterior cranial fossa injury. If there is battle sign, that is a hematoma over the mastoid process, we have to think of a middle cranial fossa injury, or sometimes cavernous sinus thrombosis. So battle sign, that is a hematoma over the mastoid, because of the mastoid emissary getting occluded in cavernous sinus thrombosis. It can happen in cavernous sinus thrombosis, or it can happen due to middle cranial fossa injury. Then ligature marks and injuries over the neck have to be carefully looked for, often missed and relatives might not reveal. Then look for jaundice, tongue bite, smell of poisons. And petechia in the eyes can happen in fat embolism. Methyl alcohol poisoning, look for optic nerve edema and congested retina. And subhyaloid hemorrhages, that is D-shaped hemorrhages in the fundus, appear as consequence of rapid increase in intracranial pressure. That is called as Terson syndrome, which happens in subarachnoid hemorrhage, or usually it is seen in subarachnoid hemorrhage. Then examine the skin, look for prick marks. That will tell us about drug abuse. And cherry red spot, cherry red color of the skin is seen in carbon monoxide poisoning, and grayish blue in methemoglobin or aniline dye poisoning. And telangiectasia is seen in liver disease, arteriovenous malformations in the brain, and splinter hemorrhages and osseous nodules, subacute bacterial endocarditis, related complication, it may be multiple cerebral abscess, and rash and bleed suggests Waterhouse Friderichsen syndrome. That's a complication in meningococcal meningitis. And you can have SR marks that happens in tick bite. Then you have to do a quick systemic examination of, after having a general observation, do a quick systemic examination of all the systems very quickly to pick up areas where you need the help of experts. Then we look at the respiration. We know that respiration is controlled by, from the lower motor neuron, the muscles of respiration, that's the diaphragm, intercostal muscles, to the central rhythmic control of respiration. So the peripheral structures, we know it is the intercostal nerves, the with the adrenergic and noradrenergic and motor neurons which control the diaphragm and the intercostal muscles. Then we have got the various structures in the brainstem like the lower cranial nerves, the nucleus of the tractus ambiguus that regulate respiration at the pharyngeal phase. The pharyngeal phase, we know that the oropharynx and nasopharynx is there. The oropharynx should close and nasopharynx should open so that they work in coordination and food doesn't go into the air and air doesn't go into the food tube. That is happening in the brainstem cranial nerve nuclei, which are controlled by higher structures like parabrachial nucleus, hypothalamus, and prefrontal cortex. So at the periphery, various intercostal nerves and the diaphragm controlled by the autonomic as well as the motor afferents and efferents. Then in the pharyngeal phase, we have got controlled by the lower cranial nerves, and we have got a brainstem swallowing center, which integrates and coordinates swallowing and respiration so that both do not interact with each other. Then we have got the hypothalamic center, and we have got the prefrontal cortex, which is the highest center. So pulmonary stretch afferents go through the 9th and the 10th nerve and enters the nucleus of the tractus solitarius, and reticular formation of the ventrolateral medulla and pre-boxing complex results in the maintenance of the rhythm of respiration. We have got an inspiration, we have got an expiration, and they go in a sinusoidal manner, and that is maintained by the ventrolateral medulla. And parabrachial nucleus of the pons decides the depth to which you inhale and you exhale. And neurons in the intertrigeminal region coordinate swallowing and respiration. So when we are swallowing, the respiratory tract should be closed. So this coordination is done by the neurons in the intertrigeminal region. So what are all the, apart from the general observations we have made and systemic examination we have made, we will see the respiratory pattern. So Cheyne-Stokes respiration. So the respiration waxes in a smooth crescendo phase and then in a decrescendo phase, and apnea is reached in 10 to 20 seconds. So you have got a crescendo followed by decrescendo, which ends in the apnea, which in about 10 to 20 seconds. The hyperpnea lasts longer than the apneic phase. So they will have hyperpnea alternating with apnea. Hyperpnea lasts longer than the apnea. And Cheyne-Stokes respiration is a sign that intact brainstem. You see, intact brainstem produces this respiration, but why apnea is taking place? The forebrain pathways which inhibit apnea are lost. So it is by the frontal respiratory control pathway that inhibits apnea. So this is not there. So hyperpnea and apnea is going on alternating. If the frontal connection is intact, apnea will be inhibited. So this does not take place. When it is disconnected, the brainstem centers produce alternating hyperpnea and apnea. Next is neurogenic hyperventilation. Here it is not alternating apnea and hyperpnea like Cheyne-Stokes. Here it is a fast respiration, and the lesion is in the central tegmentum of pons. It is the rate control center. Apnea inhibitory center is the frontal center. When that is not there, above the pons lesion, we get Cheyne-Stokes respiration. And when there is a lesion at the level of the central tegment of the pons, the respiratory rate becomes very high. It is more than 25. It may be 40 to 70. And this happens in acidosis and hypoxia. Then there is what is post-hyperventilation apnea. Hyperventilation lowers the arterial carbon dioxide tensions, which inhibits the respiratory drive. As we know that carbon dioxide is a stimulus for respiration. So when there is hyperventilation and carbon dioxide is washed out, there is inhibition of the respiratory drive. So metabolic drive for respiration when not sensed due to brain damage. And then apnea occurs. So this is a situation when the metabolic drive for respiration is not sensed by the brain due to dysfunction of the respiratory control mechanism. Next is the apneustic respiration. 2 to 3 seconds passes at the end of inspiration and expiration. This is seen in apnea, apneustic. Every 2 to 3 seconds, there is no hyperpnea and apnea unlike chain stroke breathing. Here at the end of every inspiration and expiration, there is apnea. But there is no hyperpnea. That is called apneustic breathing. And this is seen in dorsolateral pontine lesion. Then ataxic breathing, irregular gasping respiration due to pathology of the respiratory rhythm generator at the pre-Botzinger level of the upper medulla. So then it becomes a very irregular, unpredictable respiration with a deep gasping, and it is irregular. And Kussmaul's breathing is a deep, regular respiration observed in metabolic acidosis. And cluster breathing or Biot's breathing is a highly erratic respiratory pattern. And periodic respirations that are unpredictable, irregular in frequency and amplitude, with variable pauses between clusters of breath seen in high medullary damage. That is called Biot's breathing. So this respiration, if you have chain strokes, it is frontal. Hyperventilation, it is pons. Ataxic breathing, it is medulla. So it helps us to localize partly where could be the pathology. So here you can see frontal damage, you get a hyperpnea followed by apnea. And pontine lesion, you see hyperventilation. This is apneustic breathing. Yeah, following every breath, there is a period of apnea. And this is a Biot's breathing, erratic, irregular breathing. Or sometimes when the disease is very severe, you go into respiratory arrest. So next is, so we have seen the respiration pattern and see whether it helps us to localize the pathology. Then we'll look at the pupil. Normal pupil with abnormal eye movements is a very important clue. Supposing the pupils are normal and eye movement are abnormal, it is metabolic or drugs. With some exception, like morphine poisoning, domperidone poisoning, atropine poisoning, people will change. Otherwise, drugs affect only the eye movements and not the pupil. So you have to look at the pupil. I will tell the other features in the pupil grossly when we go to subsequent slides. So first dictum is normal pupil, abnormal eye movement, which is drugs or metabolic with some exceptions. That's all. Then Dalsey phenomena you have to see to know how much is the reflex eye movement. In the absence of any sedatives or anti-epileptic medication, Dalsey phenomena helps us to find out the integrity of the brainstem. Then look at the fundus for features of raised intraocular pressure, subhyaloid hemorrhages, petechial hemorrhages, methyl alcohol poisoning, all have characteristic fundus appearance. Then signs of meningeal irritation to find out CNS infections. And then focal or generalized neurological deficit again helps us to localize the problem in the various parts of the neuroaxis. So if there is a hemiplegia, we know the opposite supratentorial. If there is a brainstem fusion, we know it's an infratentorial pathology. So like that. So all these phenomena help us to localize the site. So now we see the pupil. You have got a metabolic disease. You get a small reactive pupil or normal pupil. Then in diencephalic lesion, you get small reactive pupil. And if you have a lesion of the third nerve due to ungual herniation, you get a dilated pupil. Third nerve getting compressed due to ungual herniation, there will be dilation of the pupil. Then midbrain, you get either a correctopia, that is the oval pupil, or it's a mid-position fixed pupil. Midbrain lesion produces oval pupil or mid-position fixed pupil. Then you come to pons, you get a pinpoint lesion, pinpoint pupil in pontine hemorrhage. That is very dictum, hyperpyrexia, quadriplegia, and pinpoint pupil, pontine hemorrhage. And large fixed pupil is dorsal midbrain. So normal people with abnormal eye movement is metabolic. Then small reactive diencephalic, dilated unilateral is ungual herniation, and mid-position fixed or oval pupil correctopia is midbrain. And dorsal midbrain, you get a large fixed pupil, and pons, you get a pinpoint pupil. Then what is the ciliospinal reflex? Supposing following an anesthesia, patient is in prolonged coma. There are many methods by which we arouse how much is the damage that would have happened. One is looking at the fundus for cherry red spots. The next you look for the ciliospinal reflex. It is the earliest to recover while the patient is recovering from anesthesia. And if this does not recover for more than few minutes, that indicates that the hypoxia is fairly bad. Pinching the skin of the neck will dilate the pupil to 1 to 2 millimeters bilaterally. That is normal ciliospinal reflex. This is a spinobulbospinal response. Spinal dorsal horns to brainstem autonomic structures get stimulated when you pinch the skin, and this information descends to the CI to D1, that is a thoracodorsal sympathetic outflow, sympathetic preganglionic neurons. So the afferents, when pinching the neck, goes through the dorsal gone, dorsal root ganglia to the brainstem autonomic system and descends to the CAD1, the sympathetic, and this, if it is lost within few minutes of stopping anesthesia, that again indicates a significant hypoxia. A normal response will be seen in lesions in the rostral pons or higher. And early loss indicates severe hypoxia due to various causes. So it can be normal in lesions of the dorsal pons. Then eye movements, varying types of eye movement abnormalities are there, but some important ones. Ocular bobbing, where the eyeball goes down quickly and comes back. Then the lesion is in the pons. Ocular dipping, the eye movement goes down slowly but comes back quickly. That is metabolic. And roving eye movements, that is, eye movements are going right, left continuously as if it is scanning the environment. That indicates bihemispheric damage. And absent eye movement, metabolic, drugs or brainstem pathology. Opsoclonus happens in opsoclonus myoclonus syndrome, that is skin bones encephalitis, which may be paraneoplastic or viral. And gaze changes. So I will look at the side of pathology in a hemispheric damage, and eyes will look away from the side of damage in brainstem damage. So it helps us to localize where is the disease in the hemisphere or the brainstem, correlating the gaze with a neurological deficit. Skew deviation indicates the brainstem involvement, and down and in eyes is called thalamic eyes. So supposing there is a thalamic hemorrhage, so the eyes point down and in. So these are the gross clues from eye movement. Then we come to the motor response. So posturing responses. So flexion of the upper limbs and extension of the lower limbs. That is called decorticate posture. So this decorticate posture is mediated by the drooporospinal pathway. So, but this is inhibited by the cortical motor pathways. Normally, we don't have to remain like this in a decorticate position. We have voluntary control over our motor activity. So, cortex helps us to move. So, when this cortical function is damaged, but rubrospinal pathway is intact. So, below the red nucleus, the structures are intact. Then you get this path. So, if the patient is decorticate, you know that patient's pathways below the red nucleus are all right, but it is disconnected from the cortex. So this is extension of both lower limbs and extension and internal rotation of upper limbs. This is called decerebrate posture. This posture is maintained by the vestibulospinal pathway. So if this posture is there, you know that the vestibulospinal pathway is intact. So the lesion is above the vestibulospinal pathway that produces this decerebrate posture, and this is much worse than decorticate. And so it is a very significant prognostic relevance of a very bad prognosis, and they can have abnormal eye movement, and this can happen in diffuse metabolic disease resulting in a medullary areas disconnected from the higher cortical centers. So we have gone through various definitions, various depths, gross general examination, systemic examination, respiration, and postures, pupil and eye movement. And after this, we put all the data and try to characterize. then we characterize your patient as coma with focal or lateralizing signs. So we have collected all the signs. So we are finding a patient, he is comatose with focal signs. This happens in cerebral tumors, hemorrhage, abscess, infarctions. So that is after the evaluation, gross evaluation, there's a quick characterization. That is coma with focal signs. Coma with focal signs, point a focal disease resulting in coma. Coma without focal signs, but with signs of meningeal irritation. So focal signs are not there, but there are meningeal irritation that happens with meningitis and subarachnoid hemorrhage. Coma without focal or lateralizing neurological signs of meningism, that is hypoxia, hypoglycemia, intoxication, systemic infection, seizures, and drugs or thermal injury. So coma with focal signs, coma without focal signs with the signs of meningeal irritation, and coma without focal signs but no signs of meningeal irritation. So at the end of collecting all the data, we group them into three: coma with focal signs, coma without focal signs with meningeal irritation, coma without focal signs with meningeal irritation. So these are the three categories into which we push our comatose patient after this gross assessment. So this is an acute neurological illness. So we have to measure, document so that we will know. So now we have characterized and then we have document so to follow up and see what is happening. Is the patient improving or deteriorating? So to assess that, we have to calibrate. So one is, so this is supraorbital pressure. So we saw the decorticate, decerebrate posture. So this is called Edinburgh sign, sternal pressure. That will elicit the decorticate or decerebrate posture, which may not be obvious when the patient is lying down. So this is one method, that is pressure on the over the medial canthus in the medial orbital region or over the sternum. That is called Edinburgh's test. That will release the posture which is slightly masked in some patients. So that you elicit. So now we are going to elicitation. So far we had been observing. So we all know about the Glasgow Coma scale. It measures three parameters. One is eye opening. Next is motor response. Third is verbal response. So eye opening normal, spontaneous, eye opening to call, and eye opening to pain. That is the grade. And motor response normal. It is not normal but localizes pain. And motor goes into flexion, goes into decorticate posture, goes into decerebrate posture. We saw that decerebrate means vestibulospinal pathway, damage in the medulla, where the respiratory and cardiac centers are there and carries the worst prognosis. Then comes the verbal response. It can be normal, or patient may be making incomprehensible sounds, or he may use inappropriate words, or he may be disoriented, and total score is 15. For ventilated patients, we have got another thing called 4 score. That is otherwise called full outline of unresponsiveness. And it is a 17-point scale with the potential scores of 0 to 16. So decreasing scores indicates worsening levels of consciousness. Domains measured are eye responses, motor responses, brainstem reflexes, breathing pattern. And verbal response is removed as the patient is intubated. So for intubated patients, verbal response need not be scored. That is why we are having the 4 score. So this is the 4 score. We look at the eye response, we look at the motor response, and we look at the brainstem reflexes. So this one includes the pupil and the respiratory pattern. So that is 4 score. For people who cannot speak because of exogenous agents, that is, they are intubated. So if you put he is not verbalizing and the score is very poor, that will be a fake score. That is why this 4 score is introduced. Then we have got other scores like AVPU or ACDU. ACDU is alert, confused, drowsy, unresponsive. It's gross. So gross, you can say he is alert, confused, drowsy, unresponsive. Or you have got AVPU, that is alert, responsive to voice, response to pain, and unresponsive. So these are other scores which are less commonly used. Commonly used is 4 score for ventilated patients and Glasgow Coma scale for non-ventilated patients. So then we have done the Edinburgh test to elicit the posture. Now we are doing the caloric test to know the intactness of the brainstem. So you have to check whether the tympanic membrane is all right. If the tympanic membrane is perforated, we will not do the caloric test. It gives information of the integrity of the vestibular apparatus, its connections in the brainstem and its connection with the cortical centers. So you can either use 50 ml of cold water or 3 to 5 ml of ice water. Ice water means less amount is enough. So cold water, normal response, the ice deviates slowly towards the irrigated air and then corrective nystagmus happens towards the opposite. So opposite side. So we call it as cows. Cold water, ice move towards the same side and nystagmus to the opposite side. And complete absence of ocular movement on caloric texting indicates irreversible damage to the brainstem. When cortical functions become progressively depressed, nystagmus disappears. So when you do the cold calorie test, previous days people used to do cold and warm calorie and bilateral syringing to elicit the vertical eye movements. So cold means ipsilateral deviation, warm means contralateral deviation, and bilateral means upward or downward deviation. Instead, you can just do a ice cold water after checking the integrity of the tympanic membrane. And then if the eye movement is totally absent, it indicates irreversible damage to the brainstem. And if you find that nystagmus is absent, it indicates cortical dysfunction. So it can help us with reference to cortical dysfunction or brain dysfunction. Then when do you think that apart from your patient is having a coma with focal signs? So these are bedside only, all these caloric, then you go to the imaging, blood testing, all those. So coma with focal signs are suspected not only when there is a paralysis, but also when there is unequal pupils, gaze deviation to one side, facial asymmetry, unilateral hypo or hypertonia, asymmetrical deep tendon reflexes, unilateral plantar response, unilateral seizures. So apart from paralysis of one side, you can take all these parameters: pupillary asymmetry, gaze deviation, facial asymmetry, hypo or hypertonia, asymmetrical tendon jerks, and response, plantar response, seizures. All these, if they are present, that is coma with focal signs. Then after this, we do after this Edinburgh test as well as this caloric stimulation. We go to the laboratory evaluation. You have to do routine investigation to exclude systemic disorders, complete urine analysis, estimation of urea, sugar, creatinine, liver function, electrolytes, chest X-ray, blood levels of poisons, poison assessment in the gastric content, blood, urine, and other materials to be examined, and cerebrospinal fluid should be examined when there is coma without focal signs but signs of meningeal irritation. Then further tests are decided based on the clinical examination and progress of the case. So basically, you do the blood examination for various systems as well as the metabolic parameters, the level of poisons, and then you look at the CSF, and further evaluation depends on the course of the patient. So further tests are determined by clinical examination progress of the case. Then EEG, CT scan, isotope scan are indicated in some of the patients based on what findings we have seen. So what are the features of herniation? We can look at the ungual herniation, respiratory pattern. You can have normal respiration sometimes in the early ungual herniation, or you can have sustained hyperventilation or chain strokes breathing. So in the early ungual herniation, it can be normal, but later it can become hyperventilation or chain strokes. And pupillary signs, it can be moderately dilated and constricts sluggishly to light, and later becomes the Hutchinson's pupil. So where one pupil is dilated and does not react to light at all. Initially, moderately dilated and slightly constricts. Later, one pupil become very large and does not constrict. Then oculocephalic and oculovestibular responses. Oculocephalic is Dolce, oculovestibular is choleric syringing, is usually present or disconjugate in the early stages, and in the late stages, it is showing in the late stages of angle herniation, it may become sluggish. Then in the motor responses, you can have contralateral extensor plantar response in the early stage, and in the late stage, patient goes into decorticate posture with bilateral extensor plantar response. Then we will go to central herniation. In the early stages, patient can have normal respiration with a deep sighs or yawning. So we will think, is the patient sleepy? Like that, central herniation. Then they can have chain strokes breathing. And then the late diencephalic stage, they progress into full chain stroke breathing because the cortical inhibition of apnea is not there. Then the pupillary size reactions. To start with, it is a small pupil and a small mild constriction, and later it becomes small pupil which is poorly constricting. Then Dolce phenomena, initial stage that is a full movement, and in the late stage, the movement becomes absent nystagmus because of the cortical connection we're getting lost. Then motor responses, they can have bilateral plantar response, and late they go into decorticate posture. Then you have got the midbrain or upper pond stage. So there the patient has got sustained regular hyperventilation, and rarely they get chain strokes. So neurogenic hyperventilation, rarely chain strokes. In the late pontomedullary stage, they go into shallow rapid breathing, and or they can have a biots or the ataxic irregular breathing, which we have just discussed. Then pupillary signs, mid position and often irregular in the early stage, and mid position and fixed, not reacting in the late stage. And oculocephalic, usually impaired and maybe disconjugate. And in the late stage, there is no oculocephalic response. And the motor response, patient is decerebrated. And in the late stage, they go into flaccid paralysis. So these are the various features of herniation. Then what is reverse herniation? Supposing you have a pathology in the infratentorial compartment, like a posterior fossa tumor, that is expanding and pushing the brainstem structures across the tendorium up. So they will have, they go into sudden onset of coma. So because cortex and the supratentorial structures are intact, the other features may be very much less. And suddenly, because the brainstem vital structures are there, posterior fossa lesions can be apparently innocuous, and they suddenly push the patient into coma. And localizing brainstem signs precede or accompany the onset of coma. So just before the coma happens, because the posterior fossa structures press directly on the brainstem, unlike the various other herniation where the supratentorial lesions indirectly compress the brainstem by herniating, whereas the reverse herniation, it is upward pushing. So the direct brainstem signs appear very early. And pupillary and oculomotor abnormal findings are always present. And abnormal respiratory patterns are very common because it is the direct compression on the vital respiratory centers. So that is reverse herniation. That is from below, the herniation goes up. So we can see this is subphalceal herniation, and this is transtendorial herniation, and this is shift of one hemisphere to the opposite side, and then this is transforaminal herniation. So subphalceal, ungual, and one hemisphere going to the opposite side, and this is transforaminal herniation. Next, we have got what is called a catatonic stupor. That is, you have to use the Bush-Francis criteria. These catatonic patients can remain in an unresponsive state sometimes for weeks to months. And they get bed sores, but it is all, mostly it is psychogenic and sometimes it is autoimmune encephalitis. Their eyes are open and apparently it looks that they are not seeing and may not blink to visual threat. So Manas reflex is absent and they have normal pupillary and oculovestibular responses and they are resistant to examination. So Gigan-Carlton-like. So when we want to extend, they will do it in the, they will oppose, they do not cooperate, inability to cooperate for passive examination. That is what we call Gigan-Carlton. We try to extend the elbow, they resist it and flex it. So that is resistance to examination. Every movement is like that, involuntarily opposed. And they can have autonomic and endocrine abnormalities. And later they are able to recall events. When they recover, even though apparently they are unrecording and unresponding, later they recall all these events. And they will be motor paralysis and incontinent and non-communicating. That is catatonia. And psychogenic catatonia, EEG is normal wake record. Whereas catatonia can be a feature of vasculitis, autoimmune disorders, where you will have EEG abnormalities. So now we have seen how we are going to evaluate the person and decide coma with focal signs, without focal signs, with meningeal irritation, without meningeal irritation, and grossly evaluate them. So now so this is the flowchart. An unconscious patient is arriving. So secure airway, establish adequate ventilation, and you look at the pulse. If it is there, you get an IV set and start infusions of glucose, thiamine, and imagining there is a opioid compound poisoning. And naloxone is also given, which is endemic in some parts of the world. So when they come in coma, we give glucose, thiamine, and naloxone. So if the pulse is not there, start resuscitating. And if there is, you have to start resuscitating. Pulse is not there. Next, if the patient is having seizures, start the seizure as per status protocol. And if there is no seizures, patient usually awakens with basic resuscitations like glucose, naloxone, and thiamine. And then you investigate for the cause of this unresponsiveness by checking the blood parameters. And if there is PCO2 and PO2 alteration, then you look for the respiratory failure and help them with the respiratory support. And if the PO2 and PCO2 is not altered, look at the body temperature and manage hypothermia or hyperthermia. And if there is meningeal irritation present, then investigate for meningitis or encephalitis or subarachnoid hemorrhage. If there is no meningeal irritation but pupillary abnormality is there, then you look for naloxone poisoning. We said that normal people and abnormal eye movement is drugs or metabolic, but there are exceptions like opioid poisoning, domperidone, atramine, where the pupil becomes abnormal. So unresponsive person with the abnormal people in endemic areas, think opioid poisoning and give naloxone second dose. If he awakens, it confirms it is opium. If he is not awake, then you look at various parts of the brainstem where you get pupillary changes, pinpoint people in points, and mid-position people in midbrain, and those things are uncal herniation, asymmetrical people. So pinpoint people in a coma without focal signs. In some parts of the world, it is opioid, and India is also becoming like that. So a second dose of naloxone given. If that doesn't wake up the patient, look for structural brainstem damage. Then if you are not getting any pupillary change, then go to the, by this time only you are going to take an elaborate history, elaborate physical examination, and then look for an unexplained etiology, which is different from the common causes. The masses, mass lesions, that is coma with focal signs, maybe supratentorial, subtentorial, or metabolic encephalopathy, or even catatonic stupor. So first you ask some vital questions. What about the pulse? What about the seizures? What about the PO2, CO2? These are the basic things which we do. And using these 4 or 5, that is temperature, pulse, seizures, PCO2, PO2, we do the first level of resuscitation. If those things are not helping, then we are going to elaborate evaluation of the cause of the coma. So this is the same management protocol. ABC, intubate, stabilize the cervical spine, supplement oxygen, IV access, blood pressure support, sugar and thiamine, and treat the causes like seizures. And if needed, you start antibiotic, naloxone, flumasil, depending on what kind of poisoning, flumasil, if it is for paracetamol, opioid, common naloxone, gastric lavage, and activated charcoal if you are thinking of drug overdose. ICP, reduce, use mannitol. Seizures, use anticonvulsants. Then stabilize the vitals, recognize, treat primary cause. That's the next step. Then protect the eyes from exposure. Up now you have resuscitated the patient quickly, and now you are going to treat the cause, underlying cause, and now you are in the patient is going to be in coma for longer time. Exposure keratitis, bed sores, pneumonia, DVT, urinary infections, contractures, malnutrition, dehydration, all these are going to come during the period of treatment. So all this should be addressed as the third part. First part is keep the person alive. Second part is treat the cause. Third part is prevent complications of prolonged treatment. So take home message for a comatose patient, keep the patient alive, and specific treatment depends on the cause. Alive if possible. So that is what I told. PO2, PCO2, pulse, blood pressure, temperature, all these are corrected irrespective of the cause. Then we will investigate for the cause and treat specific management and prevent long-term complications. Thank you. Yes, ma'am. Yes. Yes. You see, as I told, locked in syndrome, patient is immobile, unresponsive, but is registering everything. But the tragedy is, it can even be a case of advanced Guillain-Barré syndrome, where he has facial palsy, cranial nerve palsy, completely paralyzed, but he is recording everything, unable to communicate that he is conscious. So sometimes in one occasion, I have seen a patient with very severe Guillain-Barré syndrome being suspected as brain death. So here the clue will be, you can do an EEG. You see, that is very vital. Somebody suspecting a very conscious patient, he'll be very apprehensive. So he is de-efferent. He receives everything, but he cannot express it to us. After some time, when he recovers, we know that he has been registering everything. That is locked in. So he is locked in. Whereas persistent vegetative state is at least 1 month, patient looks awake. Usually they lie with the open eyes. They move their eyes this side, that side. They swallow, they breathe, but they neither record nor respond. So persistent vegetative state, after 1 month, they generally the prognosis very bad. They do not recover at all. Eyes are open. Apparently, you will think my patient is conscious. He is not registering, not recording. Vegetative state. It is a self-explanatory word. So vegetative functions means what? Eating, swallowing, and looking. So he is eating, he is swallowing, but he neither registers nor responds. That is persistent vegetative. Locked in is much better. Most of these patients recover. It may be ventral pontine syndrome, or it can be Guillain-Barré, severe early Guillain-Barré. They are not able to move anything. Sometimes even in end stage Parkinson's disease, they are rigid, stiff, immobile, they are locked in. But they know everything. Once they recover, they communicate that how frightened they were, that we will think they are brain dead and take out their organs. No? So that's a better condition. Locked in state is a better condition. Most of these patients come out of this, and when they come out, they tell us that they were fully conscious. Vegetative patient has got only vegetative functions. Vegetative is self-explanatory term. Only vegetative functions are there, nothing else is there. So I do not understand the question. Do you mean a psychogenic catatonic state or a self-induced drug abuse? So I can only think of two conditions from what you are telling. You see, drug, as I told, if it is catatonia, you have to apply the Bush-Francis criteria. So they are immobile, motor paralysis. And when you examine, they will have Medgigan or Giggen-Halton. So Giggen-Halton is inability to cooperate for passive examination. So you want to passively extend, they flex. You want to passively flex, they extend. And they may have lot of grimacing, posturing. What we call Medgigan, or Medgigan is you just move your limb in front of the patient, they may passively follow. You will think they are voluntarily following. And they lie down like that, not mute. They are mute, immobile, and they can show autonomic features like palpitation, sweating, grimacing, and Medgigan. Their EEG is normal, and it is catatonic schizophrenia, where they remain immobile like that, and they best respond to electroconvulsive therapy. Whereas this kind of Bush-Francis criteria can also apply to catatonia happening in organic disease like lupus or autoimmune encephalitis. So to know whether it is a catatonic stupor, if the patient is having Giggen-Halton or Medgigan, motor unresponsiveness, verbal unresponsiveness, irrespective of whether it is psychogenic catatonia of schizophrenic type or catatonia of organic type, you give an IV lorazepam. Intravenous lorazepam alerts them and makes them temporarily all right. So irrespective of the cause of the catatonia, lorazepam reverses their state. That is catatonia psychogenic. It's not self-induced. It's a psychiatric disorder. They don't want that psychiatric disorder. It happens. And even in autoimmune encephalitis, catatonia is not self-induced. Otherwise, it is a self-induced coma due to IV drug abuse. You will find the pupillary changes, eye movement changes, pinpricks, then blood level, urine level. Otherwise, I don't know whether you are meaning malingering. Malingering patient, everything will be normal. He lies with the closed eyes, and you can look for people is normal, fundus is normal, eye movements normal, reflex is normal. And you see that Rosenbach sign, that when you put your fingers on the lids of the patient is trying to scan the environment. So there will be eyelid flickering. That is called Rosenbach sign. So these are malingering, simply behaving. And that is one opossum syndrome and all we say. So people, even animals, when they are seeing the predators, lion or tiger coming to attack, some of the animals lie as if they are dead. That is called opossum syndrome. So what exactly you mean by self-induced coma, I don't know. Yes, I thought catatonia is a psychiatric disorder. So whether you are thinking like that, or it's a drug-induced coma, or you are thinking of malingering, each one has to be differentiated by the findings that we have gone through now. Thank you. Thank you.